Around 70% of women will experience the symptoms of genitourinary syndrome of menopause. 70%. I mean, we're talking about a vast majority of the population undergoing, fundamental physical changes to their pelvic anatomy.
Yeah, it's a genuinely massive demographic.
Right. Yet, according to data from the NHS Golden Jubilee, only about 7% of those women actually seek advice and treatment from a medical professional.
Which is just a staggering gap.
It really is. That massive gap between the 70% who are experiencing this reality and the 7% seeking help, it represents millions of people just living in silent daily discomfort.
Well, it highlights a culture of normalization around pelvic pain. For decades, women have been culturally conditioned to view severe pelvic discomfort during and after menopause as just an inevitable part of aging, like something that just has to be endured.
Instead of a mechanical, biological issue with highly effective treatments.
Exactly.
And that silent endurance brings us to the core mission of today's deep dive. We're exploring a very specific, vital question that you might be wondering about yourself or perhaps for a loved one. And the question is this: can untreated vaginal atrophy actually cause pelvic organ prolapse?
And to answer that for you, we are synthesizing a really robust stack of specialized medical sources today. We are looking at the official clinical guidelines from the National Institute for Health and Care Excellence, known as NICE.
Right.
We're cross-referencing those with regional NHS guidelines from Forth Valley, Royal Devon, Tayside, and the Golden Jubilee. And we also have insights from the British Association of Aesthetic Plastic Surgeons, the BAPS, and the specific clinical perspective of Mr. Joe Daniels,
Who's a consultant gynecologist at the Women's Health Clinic. Right?
Yes, exactly.
Okay, let's unpack this, because to get to the bottom of the prolapse question, we first have to understand the biological environment of the female pelvis during menopause. We really have to look at what Genitourinary Syndrome of Menopause, or GSM, actually does on a cellular level.
And it all basically comes down to the role of estrogen.
Right, because we generally think of estrogen as just a reproductive hormone, something that regulates the menstrual cycle. But reading through these NHS sources, it becomes incredibly clear that estrogen is essentially the structural foundation for the entire pelvic region.
It really is. Estrogen is the primary driver of blood flow to those pelvic tissues. So when a woman enters menopause, the dramatic systemic drop in estrogen effectively starves the vulva, the vagina, and the surrounding structures of that blood supply.
It literally starves them.
Yeah. On a microscopic level, estrogen is responsible for maintaining the thickness and elasticity of the vaginal epithelium, that's the surface lining. It stimulates the cells to produce collagen and elastin.
Right.
So without it, the tissues literally change color. They become pale due to the lack of blood flow, and they begin to severely thin out.
I was kind of thinking of it like a sponge. Like a sponge relies on water to stay plump and flexible.
That's a great analogy, actually.
Yeah, and without the estrogen, the sponge becomes dry, brittle, and suddenly it's prone to microcuts and tearing from almost no friction at all.
Exactly. And the symptom list from the NHS Golden Jubilee source paints a very clear picture of what that starvation looks like in practice.
Because it goes far beyond the commonly known symptom of vaginal dryness. I mean, the lack of estrogen causes the physical shrinkage and architectural change of the labia and the clitoris.
Which can become highly sensitive and incredibly painful.
Right. And some women even experience a watery discharge as the vaginal microbiome shifts.
Oh.
And I also found it fascinating to read about old episiotomy scars.
Oh, yes. The episiotomy scars are a perfect example of how structural this hormone really is.
For context for you listening, an episiotomy is a surgical cut made at the opening of the vagina during childbirth to aid delivery. So women might have had that procedure 30 or 40 years ago, and the scar tissue healed perfectly fine.
But scar tissue is inherently fibrous.
Exactly. It relies heavily on estrogen to maintain whatever flexibility it has. So when estrogen drops at menopause, that old fibrous tissue loses its elasticity completely. It becomes rigid, causing significant pain literally decades after the original procedure.
Right. And if we connect this to the bigger picture, this cellular starvation doesn't isolate itself to reproductive or sexual function. It fundamentally compromises the urinary system as well.
Oh, wow.
Yeah. The lower urinary tract, specifically the base of the bladder, which is known as the trigone, and the urethra, they are embryologically derived from the exact same estrogen-dependent tissue as the vagina.
Meaning the bladder and the urethra are suffering the exact same thinning and inflammation as the vaginal walls.
They are. The biological mechanism here is directly tied to the microbiome. In a healthy, estrogen-rich environment, the vaginal cells produce a sugar called glycogen,
Okay.
and good bacteria, primarily lactobacilli, feed on that glycogen and produce lactic acid. That keeps the entire area acidic and hostile to bad bacteria.
So it's like a natural defense system.
Exactly. But when estrogen drops, glycogen production stops. The good bacteria die off, the pH level rises, and suddenly the area becomes a breeding ground for bacteria that cause urinary tract infections.
Right, and the sources emphasize that many women experience what feels like a severe recurrent UTI. The urgency, the burning, the frequency. But when their urine is tested in a lab, there is zero bacterial infection present.
Which is incredibly frustrating for patients.
It has to be. The pain is purely a result of the raw, thinned-out tissue of the urethra being constantly irritated by just the normal passage of urine.
Yeah, it creates a debilitating cycle of discomfort that, frankly, severely limits a person's quality of life.
Right, so understanding that the entire mucosal lining of the pelvis is thinning out, losing elasticity, and becoming structurally compromised brings us directly to our core question for this deep dive. If the tissue forming the walls of the vagina is decaying and shrinking like that dried-out sponge, does this structural failure cause the heavy pelvic organs resting above and around it to simply fall out of place? Basically, does untreated vaginal atrophy cause prolapse?
And we have a definitive clinical answer to that exact question from Mr. Joe Daniels, the consultant gynecologist at the Women's Health Clinic. The answer is no.
No.
Untreated vaginal atrophy does not cause pelvic organ prolapse.
I have to admit, reading that initially confused me a bit.
Oh, really?
Yeah, because looking at the NHS Fourth Valley guidance, they describe the pelvis as a cavity supporting the bladder, the uterus, and the bowel. So if the tissues lining that cavity are physically weaker and thinner due to estrogen starvation, it seems counterintuitive to say that weakness isn't causing the organs to descend,
Sure, I get that. But the confusion clears up when we separate the anatomical structures into two distinct systems. Prolapse is a failure of the musculoskeletal system, specifically the pelvic floor muscles and ligaments. You can think of the pelvic floor as a thick muscular hammock that spans the bottom of the pelvis, physically holding the bladder, uterus, and bowel up against gravity. Atrophy, conversely, is a failure of the mucosal system, the surface lining. It's akin to the wallpaper or drywall inside a room.
Ah, okay. So the muscles are the load-bearing beams holding the house together, and the mucosal tissue is just a superficial layer covering the walls.
That's a perfect way to look at it.
So weakening the drywall doesn't cause the roof to cave in.
Exactly. A prolapse happens when those load-bearing muscle fibers, the levator ani muscles, are overstretched, torn, or weakened. And that structural failure of the muscle hammock is typically driven by mechanical trauma.
Like what kind of trauma?
The primary culprits are pregnancy, vaginal childbirth, chronic constipation that requires heavy straining, chronic coughing, or repetitive heavy lifting.
Right, right. And the NHS Fourth Valley source details the 4 distinct types of prolapse, which really illustrates how this is a scaffolding issue, not a surface tissue issue.
Yeah, they break it down very clearly.
Like, you have an anterior wall prolapse, historically called a cystocele. This is where the supportive fascia between the bladder and the vagina tears, allowing the bladder to basically bulge down into the front vaginal wall.
Then there is the posterior wall prolapse, or rectusy. This occurs when the fascia separating the rectum and the vagina weakens, and the bowel bulges forward into the back vaginal wall.
Okay. And you can also experience uterine descent, where the ligaments holding the uterus stretch out, allowing the cervix and uterus to physically drop down into the vaginal canal.
And finally, urethral prolapse, where the urethra itself bulges down. And the guidance notes that it is actually entirely common for a patient to have multiple types of prolapse simultaneously.
Right. But none of those structural failures are initiated by the lack of estrogen in the surface tissue.
Correct.
Here's where it gets really interesting, though. While atrophy does not cause the prolapse, the medical consensus across literally every source we are looking at is that untreated atrophy makes living with and treating a prolapse almost impossible.
Yeah, because they exist in the exact same physical space. Ignoring the surface tissue failure creates a cascade of secondary complications.
Because it completely compromises the primary non-surgical management strategy for prolapse, right?
Yes, which is the use of a pessary.
Right, and a pessary is an internal medical device, typically made from firm medical-grade silicone or plastic. A clinician inserts it high up into the vaginal canal, and it acts as an artificial internal scaffolding.
basically propping the descending organs and the vaginal walls back up into their proper anatomical positions, which relieves the pressure and the bulging.
But we have to consider the environment that device is being placed into. If a patient has severe untreated vaginal atrophy, their vaginal canal is lined with tissue that is paper-thin, severely inflamed, dry, and entirely lacking in elasticity.
Yeah, so attempting to fold and insert a rigid piece of silicone scaffolding into that environment is incredibly painful for the patient.
I can only imagine. And once the pessary is inside, it has to rest against those vaginal walls 24/7.
And that constant mechanical friction of the silicone against estrogen-starved, fragile tissue inevitably leads to microabrasions. It causes the tissue to ulcerate, bleed, and massively increases the risk of infection.
So for a pessary to function safely and comfortably, the tissue supporting it must be plump, elastic, and well lubricated.
Therefore, the clinical guidelines are absolute. Treating the underlying vaginal atrophy is a non-negotiable prerequisite for managing a prolapse.
Okay, so we have firmly established that treating the atrophy is essential. So we need to map out the treatment landscape for you listening. If 93% of women aren't getting help from their GP, they are likely trying to navigate this completely alone.
Which is daunting.
Very.
Yeah.
And the NHS Tayside and Forth Valley sources lay out a very clear, step-by-step clinical pathway, starting with the least invasive non-hormonal options.
Right. The absolute baseline involves removing environmental irritants. That means cutting out perfume soaps, bubble baths, and flavored or scented hygiene products.
Because they strip away whatever natural moisture remains.
Exactly, and aggressively irritate the delicate pH balance we talked about earlier.
The sources also highly recommend the regular use of dedicated non-hormonal vaginal moisturizers. And it is important to note the mechanical difference here between a moisturizer and a lubricant, right?
Yes, that's a crucial distinction. Lubricants are designed for temporary friction reduction during penetrative sex.
Right.
Moisturizers are designed to be absorbed into the tissue over time to hold water within the cells, providing baseline daily comfort.
Alongside tissue hydration, the NHS guidance places a massive emphasis on pelvic floor muscle training, or PFMT.
Because a prolapse is fundamentally a muscle issue, you have to rehabilitate the muscle. And PFMT isn't just about isolated Kegel exercises. It involves comprehensive strengthening of the core and hips.
And optimizing bowel habits too, right?
Yes, to eliminate the downward straining of chronic constipation.
But moisturizers and physical therapy can only do so much. If the biological root cause of the tissue decay is estrogen starvation, at some point, the only way to restore the cellular function is to reintroduce estrogen.
And this is where we run into a major systemic point of confusion for patients.
Yeah.
The moment the word estrogen is mentioned, people immediately associate it with the systemic risks of hormone replacement therapy. You know, the pills or patches taken to manage hot flushes and whole-body menopausal symptoms.
It is basically the biggest barrier to treatment. We have to clearly separate systemic HRT from localized vaginal estrogen.
Absolutely. The treatments recommended for atrophy medications like Vagifem or Vagirux, which are tiny tablets inserted directly into the vagina with an applicator, or specific creams and silicone rings, they are hyperlocalized.
They deliver microdoses of estrogen directly into the affected tissue.
And the Golden Jubilee source confirms that these localized treatments have minimal to zero systemic absorption into the bloodstream. They do not travel through the body.
So they just stay directly in the pelvic tissue.
Right, restarting that biological mechanism we discussed earlier, stimulating blood flow, restoring collagen, and restarting glycogen production to fix the microbiome.
And because the dosage is so incredibly low and localized, they are deemed highly safe for long-term use for the vast majority of women. You can even use them concurrently with systemic HRT patches or gels.
The safety profile is remarkably robust. But there is one specific medical demographic where the NICE-E clinical guidelines mandate a much more cautious, highly regulated pathway.
And that's patients with a history of breast cancer.
Right. The intersection of breast cancer survivorship and severe vaginal atrophy is incredibly complex. Many breast cancer treatments deliberately induce sudden, severe menopause.
Specifically, the use of aromatase inhibitors. For patients with hormone receptor-positive breast cancer, oncologists prescribe aromatase inhibitors to block the enzyme that converts androgens into estrogen in the body's fat tissues.
Because the entire goal of the medication is to completely eradicate estrogen from the body to prevent cancer cells from growing.
Right. And as a direct result of that, these patients suffer from extreme, rapid-onset vaginal atrophy.
And the NICE guidelines provide a strict flowchart for this exact scenario to ensure patient safety. For anyone with a history of breast cancer, non-hormonal moisturizers and specialized lubricants are the absolute first-line treatment.
Because the goal is to manage the symptoms mechanically without introducing any hormones at all.
Yes. But if those non-hormonal options fail to provide relief, the NICE pathway states that localized vaginal estrogen is not strictly prohibited, but it requires a rigorous, shared decision-making process.
Meaning the GP cannot prescribe it alone.
Exactly. They must consult with the patient's oncology team. They have to evaluate the specific estrogen receptor status of the prior tumor and weigh the severe impact on the patient's quality of life against any theoretical risk of absorption.
Medicine also offers non-estrogen pharmacological alternatives for these complex cases, though. The guidelines mention medications like Interosa, which is the brand name for prasterone.
Right, and prasterone is essentially DHEA, a precursor hormone that the vaginal cells can locally convert into the necessary components to maintain tissue health.
Offering an alternative pathway for women who absolutely cannot use direct estrogen.
Precisely.
Now, as we navigate these treatment pathways, I found a glaring contradiction between the national guidelines and the treatments offered in the private sector.
Oh, yes.
Yeah, the Women's Health Clinic, the private practice run by Mr. Joe Daniels, explicitly lists procedural treatments for vaginal atrophy. They advertise generic PRP approaches, as well as specific energy-based devices like the Mona Lisa Touch Laser.
This brings us into the rapidly expanding field of private aesthetic and cosmetic gynecology.
Let's break down the mechanics of those private treatments first. PRP stands for platelet-rich plasma. The clinic draws the patient's own blood, spins it in a centrifuge to isolate the platelets, which are packed with cellular growth factors, and then injects that plasma directly into the vaginal tissue.
With the theory being that it will stimulate cellular regeneration and blood flow.
Right, and then you have the laser therapies, like the Mona Lisa Touch, which is a fractional CO2 laser. The mechanical concept is that the laser creates microscopic thermal injuries, basically tiny burns along the vaginal wall. The body responds to this targeted thermal trauma by sending blood flow and collagen to the area to heal the wounds, hypothetically plumping the tissue back up.
And the BAPS source notes that these types of interventions, alongside surgical vaginal tightening, are frequently sought out by women looking to address the tissue laxity and changes associated with aging and childbirth.
But when you look at the official NICE visual summary for treating genitourinary symptoms, there is a very prominent warning. It states, in no uncertain terms, do not offer vaginal laser treatment for GU symptoms associated with menopause, unless as part of a randomized controlled trial.
This raises an important question about evidence-based medicine and how national health systems evaluate risk versus reward. You know, the National Institute for Health and Care Excellence is an incredibly conservative body by design.
As they should be.
Right. Their mandate is to authorize treatments that have proven long-term efficacy and safety data across massive populations.
And the data for lasers just isn't there yet.
Exactly. The issue with fractional CO2 lasers is that you are intentionally causing thermal injury to a mucosal lining that is already paper-thin and compromised.
Right.
While short-term studies might show an increase in collagen during the initial healing phase, ENDS lacks the long-term 10 to 15-year data to prove that repeatedly burning the vaginal epithelium doesn't eventually lead to extensive mucosal scarring, nerve damage, or a worsening of the pain.
Especially when they already have a highly effective, deeply researched, low-risk pharmaceutical option in the form of localized estrogen.
Precisely. ENDS evaluates the necessity of the intervention. Laser treatments and PRP injections cost thousands of pounds in the private sector, and the BAAPS guidance explicitly warns that invasive cosmetic procedures in this area carry inherent risks of scarring, altered sensation, and infection.
So when a condition can be effectively managed with a microdose estrogen tablet that costs a fraction of the price and carries decades of safety data, the National Health Service restricts experimental physical trauma to clinical trials.
It serves as a vital reminder for patients to thoroughly research the mechanisms and the long-term data before pursuing expensive private treatments out of desperation.
We have covered a massive amount of clinical ground today. So, to you listening, let's pull all these threads together. We started with a very clear anatomical question. Can untreated vaginal atrophy cause prolapse?
And the answer is no.
Right. Prolapse is a mechanical failure of the pelvic floor muscles. Atrophy is the cellular starvation of the surface tissue. But treating the atrophy is an absolute prerequisite.
Because trying to fit a supportive pessary into a dry, tearing vaginal canal is a recipe for immense pain and ulceration.
We really have to move past the reality where only 7% of people are seeking help. The localized treatments are highly effective, they don't carry the systemic risks of traditional HRT, and they can fundamentally restore your quality of life. You have to advocate for yourself and ask your doctor for the localized support your body needs.
And on that note, I want to leave you with one final fascinating insight buried in the NHS Golden Jubilee source.
Hmm.
Culturally, we associate genitourinary syndrome exclusively with aging. We frame vaginal dryness, thinning tissue, and painful sex as an inevitable decline of the older female body. But the medical guidance points out that breastfeeding mothers frequently experience the exact same severe vaginal atrophy.
Wait, really? Breastfeeding mothers?
Yes. The hormonal mechanics of lactation actively suppress estrogen production. A 30-year-old mother nursing her newborn is experiencing the exact same cellular tissue starvation as a 65-year-old postmenopausal woman.
Wow, I had no idea.
And those young mothers are regularly prescribed localized vaginal estrogen to fix the mechanical issue, and it is viewed entirely without stigma. It is simply a temporary biological state requiring a practical solution.
That completely reframes the entire conversation.
It really does. If a young mother can openly treat this physiological reality without shame, shouldn't women traversing perimenopause and postmenopause be afforded the exact same grace? It is something worth thinking about as we change how we view and treat the female body.
That is a brilliant point to end on. Thank you so much for breaking this all down with me. And to you listening, thank you for joining us on this deep dive. Keep questioning, keep exploring, and most importantly, keep listening to your bodies.